Welcome to Healthcare Rounds. I'm John Marchica, CEO of Darwin Research Group. Today's conversation takes us to Chicago's West Side, to the Austin neighborhood, and to a hospital that sits at the intersection of community crisis and hope. The Loretto Hospital is what we call a safety net hospital, and which we'll talk about in just a minute. Joining me today is Tesa Anewishki, CEO of Loretto Hospital, and she spent much of her career inside this organization and now leads it during a period of rebuilding and renewal, focused not just on financial sustainability, but what it truly takes to improve outcomes in communities that have historically been under-resourced. Tesa, welcome to Healthcare Rounds.
Thank you. Thank you, John. Thank you for having me. I'm super excited about the conversation today.
Yeah, me too. So I said we'd talk about safety net, so let's start with that. When you say safety net hospital, what do you want people to understand in, let's say, operational terms?
Oh, wow. So safety net hospitals are community hospitals. We have a safety net designation, which really talks about how we get paid. And that just means that we serve a high Medicaid population. It's usually 40% or greater, with a 4% going to charity care, or 50% or greater. Loretto Hospital actually serves an 84% Medicaid population.
Wow, that's pretty substantial.
Yeah.
So for someone who's never been to Chicago's West Side, what does Austin and what does Loretto mean to the neighborhood?
Loretto is a beacon for the community. We've been in the business for over 100 years. We provide critical and vital general care and acute care access for the community. We are the largest employer in the community, so we contribute about $200 million to the local economy. We're the largest employer in the community, and we're vital to decreasing the healthcare disparities that are present in vulnerable and at-risk communities. And so I think, again, we're a vital resource, a vital pillar to the community.
So I know you were with the organization for a while, but when you became CEO, what was the first hard truth that you really had to confront about your situation?
Oh my goodness. I would say operations. So again, most of your community hospitals are probably at least 100 years or very close to being 100 years or greater. And so you're always worrying about infrastructure challenges, in addition to the reimbursement challenges of the hospital. So as a safety net, we get paid 32 cents on the dollar on average. And then we're, again, in 100-year-old buildings, and oftentimes anything can break on any given day. And that really makes us have to pull from our operational funds in order to accommodate that challenge. And so those are the things that really keeps me up at night is how do we get around these very low reimbursement rates, and then praying that something doesn't go wrong in the middle of the night, a pipe doesn't burst. Again, because we'll have to pull from our operational funds to accommodate that. And so we recently experienced that when our generator went out, and it was a $1.8 million fix and $20,000 to rent a temporary generator until the new one gets in. And so we're probably about 4 months into it now, and it should be fixed within the next 4 to 6 weeks.
Wow. And you said 32 cents on the dollar.
Yes, 32 cents on the dollar.
And 84% Medicaid.
84% Medicaid, yes, and then the rest is charity care. Between self-pay and charity care, that's about 11%, and the difference is about 6. I can add today. It's about 6%, 5 to 6% commercial.
Wow. If you've spent any time, and I didn't ask you to go and look in our archives, but we've spent a lot of time talking to executives in health systems, large health systems, small health systems. Nobody is working with the numbers that you have. I mean, obviously that is very clear. And so maybe again, to just bring it alive to the listeners,
Sure.
What is a typical, I'm thinking of this too, because I'm watching The Pit. What is a typical emergency room setting, typical day in, say, in the emergency room that you face?
Sure. So as a safety net, we provide care to anyone who, regardless of their ability to pay. That is our mission. And so a typical day in our ER, we get a lot of walk-ins that will come. We're in a community that unfortunately rests on something that used to be called the heroin highway. And so we have a lot of individuals who visit our emergency room who are in crisis, whether it's from a substance use disorder or they're having some mental health challenges. And then we do have patients that come that are experiencing some acute um, challenges based on some chronic illnesses or just really emergent care. And so any given day could be a myriad of individuals that walk through the doors that are in need of emergent care. And we have a staff that's there and ready to assist no matter what the challenge may be. And so we're not a trauma center. And I think that's one of the things that sometimes gets misconstrued with safety net or hospitals. A lot of us are general acute care hospitals, but not level one trauma. And so in those instances, when we do get someone who's in need of trauma care, then we do stabilize and then we transfer to one of our partnering hospitals.
Again, I want to get to that high Medicaid population. And, if we're just looking at payer mix and margins, and everybody always talks about, we want more private pay, and, the higher the private pay, then that's more profitable, right?
Right.
But there's a story behind all of this that I want to understand. And again, this is unique to Healthcare Rounds. First time we've really had somebody on from a safety net hospital. So what is the story behind those numbers? What is the story behind, the 84% and what, kind of what you're dealing with, trying to get really to more of the human story and where you are in the community and how important you are in that community?
It just means that we are situated in a community that is very vulnerable, very at risk. It's one that is generally has a lot of disinvestment or no investment in the community. And so for the hospital to be here to really address those healthcare disparities, it's tremendously important. The work that we do, there's a 20-year death gap between our institution and you take a 7-minute ride east to downtown Chicago and individuals are living 10 to 20 years longer. And so it really comes down to access to care. And that's been a challenge in most of the communities that have safety net and community-based hospitals located within them.
So, Tesa, can you talk a little bit more about that death cap and that how you define it and really what it means as CEO of this hospital?
So the death gap simply means that the life expectancy rate for those on the west side of Chicago is about 10 to 20 years younger than those 7 minutes east of us. And so our individuals in our community live to be an average of 60 years old versus 80 years old. And so in order for us to really get to a place where people can live healthier longer, we have to ensure that access to care is available to those communities. And for us, it is primary care. It is making sure that we are doing things to address the labor and delivery shortage area that we are also considered. And we want to make sure that individuals have access to the care when they need it most. And so, again, if we're talking about eliminating the healthcare disparities that were exacerbated, quite honestly, through COVID, then we have to make sure that we're offering the services that the community needs. And that also includes specialty services, which can be a challenge for safety net hospitals because the cost to provide that care can sometimes be quite expensive, depending on the specialty. For example, orthopedics is a high specialty care line. It is needed in the community. There's a lot of individuals that are impacted with, that need hip replacements or knee replacements or have back challenges. And unfortunately, your safety net organization can't really supply that on a 24/7 basis. We create innovative care models where we kind of co-share or co-partner with some of our other healthcare providers so that we at least can hold clinic for individuals that are in need of that care, and then do a warm handoff to one of our partners so that if they needed surgery, that they can get the surgeries that they need. And so oftentimes when you're in a at vulnerable or healthcare access is an issue in the community that you're served, the individuals sometimes will forego care or delay their care. And really, it does a disservice to the patient. It does a disservice to our mission. We're in the business of helping and making sure that individuals have a great quality of life in addition to having great physical health. And it's important that we're able to do those kind of things. And so, again, I think the partnership is really critical to how we do business. I try to say we can't put profit over people, and we can't talk about competition when we're talking about the lives of human beings. It has to be collaboration, and really have a innovative way of how we deliver care for the communities that we serve.
It's ironic you bring up orthopedics as your example, right?
Mm-hmm.
That's a moneymaker for a lot of hospitals and health systems, right?
It is.
But you can't view it that way. I mean,
Absolutely not. We really, again, can't be profit over people. We had an individual actually who had decided to forego care. She lived on the third floor, lived alone, and needed hip replacement, and decided to not get care for over a year. And we really engaged our case managers and care coordinators in her treatment so that she can get the care she needed through one of our partnering organizations. So again, you never want to talk about money over mission, because people are suffering, and our goal is to make sure that they don't suffer and that they have the care.
So I guess maybe I'm thinking mechanically, like how do you know this person, number one, and how does she get on your radar, and how is she tracked by a care manager? And then ultimately, because to me, what you're describing, this is really what a true pop health function in a health system should be doing. It's not just about, managing diabetics or, things that large populations. It's this specific addressing these issues in the community. But how do you do that? How do you execute? I guess I gave you a whole bunch of questions all at once, Tesa. Sorry, but I just want to know, like, in the real world, you gave an example. How does that work?
So patients will come to us for, whether they see us in the emergency room and they decide to come to our outpatient clinic and they're in need of services. So we do have a robust programs within our outpatient clinics, and we do host an orthopedic clinic, although we can't have one on staff 24/7. And so that's how the individual came to us, saying, listen, I've got some pain and some challenges. And unfortunately, during the clinic, we discovered that, okay, you need surgery. And then we did a referral, and then, she ended up coming back to us. And later on, we're like, why didn't you go get the help you needed? And it's because of the distance. The other referring organization was from her home. And in addition, she again lived on the third floor. So she's thinking, I live alone. I have 3 flights of stairs to get up. Who's going to take care of me? How am I going to get to the store? And the fear of being alone throughout that process. Ways in the decisions that individuals make when they decide whether or not they'll get care. And so, our case management team, we engage them. We happen to be a part of 2 large healthcare transformation collaboratives through the state of Illinois, where we partner with. In one collaborative, we have over 40 partners, healthcare providers, and we work in tandem with making sure that individuals, we can hand them off to an organization who can help facilitate, whether it's transportation, whether it's addressing any food insecurity needs that they may have or may be concerned about, so that they can get the procedures that they need.
So do you have formal partnerships with, say, the Rushes of the world, or I'm trying to think of who else is in your neighborhood? I guess U of C would be a little far away, but do you have formal partnerships for these kinds of services?
Oh gosh, yes, we do. For L&D, we have partnerships with Loyola University. with Rush, with some of our substance use disorder treatment programming, especially for pregnant women. We have a telehealth program where we're partners with Northwestern. And so, having those linkage agreements and formal linkage agreements in place allow us to ensure that we can, get individuals to the specialty care that they need. And so, again, collaboration, not competition. And so that's how we've been able to do a lot of the things that we're able to do.
And then do you work with other, say, federally qualified health centers in the area that also partnering with them?
Absolutely. So we have a couple of FQHCs that are located in our community, and we do partner with them so that we are available to provide the ancillary care that they need, a lot of the testing. And so we know that in Chicago right now, there's some capacity issues, and it's probably throughout the country where your larger institutions are having challenges where individuals are waiting, 2, 3, 4, even up to 6 months for diagnostic procedures. And so our goal is to really be a partner and a resource to those institutions so that individuals don't have to wait long to get a test. When you find a lump in your breast or you're experiencing some other healthcare challenge and something's wrong, it doesn't bode well for your mental well-being when you're told, yes, but we can get you in 3 months. And our goal is not to make sure that individuals have to go through that suffering. I actually had a cousin who is in Los Angeles and was going through some challenges, and his wife works at a hospital out there. I won't name it. And she couldn't get him an appointment for 4 months. And he called me and I said, listen, catch a plane, come home. And I got him in to see a specialist within a week. And he was able to take those test results and things back and immediately get treatment. So again, this is about partnership. If we are in being true to our mission to serve and to make sure that individuals live longer, healthier lives, then we have to do that in partnership with one another.
So if you had flexible capital tomorrow, just like real unrestricted dollars, where would you put that money? Where would you invest first that you think you'd get the highest return for Loretto?
Oh, I would say our surgery. You mentioned something earlier. Surgeries can bring in a lot of commercial payers. Again, you never want to lead with profit over people, but we know as a safety net based on our reimbursement rate of 32 cents on the dollar that we do need to have some kind of buffer there if a piece of equipment does go down, if something does break down within the hospital. We need to be able to attract more commercial payers to the institution to provide some of that care and testing that they may need. And that's one of the things that we know generates a large amount of commercial revenue for the hospital. We were fortunate to bring on a gynecological surgeon, Dr. Pierre Johnson, over a year ago, and he's known as the fibroid slayer, not just known throughout the state of Illinois, but he's known internationally. We just had a woman come here from Nigeria to have a procedures. We've had women come from Israel, from Canada, because he really focuses on preserving the uterus for those women who are faced with fibroids, who still have hopes to have a child. And so he's been able to do almost 100 procedures in a year, and 90% of that is commercial. So he's allowing us to kind of create that buffer and sustain our operations. And if we could replicate that 3 or 4 more times by bringing on more general surgeons and really reimagining our footprint, because we are in a 100-year-old building, there's a lot of nooks and crannies. And I think we just can reimagine the space and make that unit a lot bigger, which would increase our capacity. And then we could bring on more surgeons. We're actually got a grant to do a robotics program at the hospital. So we hope to get that off the ground in the next 3 to 4 months. So we're super excited about that. So it's really putting some imagination around our service delivery, but making sure we're being intentional about we can't be everything to everyone. And I don't think we want to mirror the larger institutions, but what are the healthcare challenges that our community is facing, and how do we be intentional about bringing in service lines to address those issues. And those are a couple of ways that I know we could do that. So I would say investment in our surgery, absolutely, an investment in our physician recruitment.
Which I was just going to get to with the physician recruitment. I mean, everybody that I talk to, this is going on for years. So this isn't just post-COVID. Shortages of nurses, shortages of doctors. How do you attract the gynecologic surgeon that you mentioned? How do you attract talent? When maybe they're being wooed by Northwestern or they're being wooed by Loyola or whatever in the area, and I imagine this is one of the most important things to you is bringing in, as CEO, bringing in high quality talent. So how do you recruit?
Relationships. You really have to find individuals that are passionate about what they do and really want to make an impact. That took a year to court Dr. Johnson. We share with him our mission, what we wanted to do with our reimagining our entire footprint, our entire campus, and how we were doing care delivery while addressing the social determinants of health, what we're keeping individuals away from getting care. And so it took a year for us to get to him. He finally agreed, but it's through relationship, and this work is really about being mission driven. You have to be passionate and really wanting to make an impact in those who do not have access to care, who would otherwise have to wait for treatment or decide to forego treatment, which we've seen in a lot of instances, and we don't want that. And he's very passionate about addressing the tremendous burden that women are facing, particularly African American women face with respect to gynecological issues like fibroids.
Mm. So talk to me a little bit about when I was doing research before this interview, I saw an article where one of your, I think, substance abuse patients had said, Loretto Hospital saved my life, right? That really kind of an interesting story. So tell me about specifically in behavioral health, some of the things that you're doing that are working and that may be a little bit novel as well.
Oh, absolutely. So as I mentioned, we're a general acute care hospital. We have a large behavioral health and substance use disorder programs at the hospital. And it is really making sure that we're always providing patient-centered care, that we're providing trauma-informed care, that we are reimagining and looking at our programming based on our population and what their needs are, and making sure that our programming is meeting the demands of the community, of the population. And so our programming, we do graduations for our substance use disorder patients, and sometimes, where we involve the family, and sometimes the family comes and sometimes they're unable to, but we always remind them it is one day at a time. And it doesn't matter who's there, we're partnering with them in their care, and that we would be there for them with them for the long haul. And so again, it's about building the relationship, the trust, and the confidence with our patients. I think that's what sets us apart. We're small enough and nimble enough that I always use the analogy. I had the benefit of going to both a historically Black college as well as a Big Ten. So I did 2 years at Xavier University in Louisiana, and I did 2 years at the University of Illinois in Champaign-Urbana. And in my 2 years at Xavier, everyone knew my name. My teachers, the president, those that worked in the cafeteria, my work study teacher, or boss. And when I wasn't in class, she would say, well, Tesa, why aren't you in class? Right. But when I went to a Big Ten, not to discredit, obviously the tremendous value of our larger universities, but I'm not sure that they necessarily knew if I was in class or not. The classes were always so large. And I think allowing us to be in a community setting is much more intimate, much more personal, and we're able to build that rapport and trust and confidence with our patients, and to make sure that they are comfortable coming to us saying uncomfortable things of how they're feeling, and not just from a physical standpoint, but again addressing some of the social drivers of health. They're having food insecurities, and we look at even that different. I think overall historically we look at social determinants of health as these vertical or horizontal buckets or vertical buckets. And really, it could be transportation may not be I don't have transportation. It may be I lost my job and I don't have gas today. So how do we get you some gas for your car so you can get to your appointment? Or looking at food insecurity, we did a community pantry about a year and a half ago. And so it was a novel idea, and we were like, this is going to be great. And we put all of this dry goods on the shelf, and canned goods. And we realized once we opened it that individuals who were coming in through our doors were hungry right now. And we were like, okay, well, dried spaghetti and canned goods that you have to warm up or cook is not doing any justice. And so we quickly pivoted that idea and we turned it into a community cupboard, which now provides single serve meals that you can eat or open the bag and you can eat right there. No questions asked. If you're hungry, you come and you get something to eat. We also recognized, based on the research, that was helping with our substance use disorder programming. If individuals are hungry and they're going through recovery, having food is a benefit to them or helping them maintain that sobriety or helping them maintain that their recovery. And so it was beneficial in a couple ways. And so now we're looking to expand that by having a free food pharmacy / grocery store, first hospital based in Illinois in the fall. And so we're super excited. So between our community cupboard and our food as medicine program that will build out of that grocery store, we think we are on the right track to making sure we're making meaningful impact with respect to those drivers.
It sounds so much to me, we start talking about safety net hospitals, that really the picture that you're describing is you're part of the fabric of the community.
Mm-hmm.
And if people are coming to you for meal assistance, or if they're coming to you for transportation assistance, again, these are things that a lot of large health systems say that they try to cover, that they try to manage, but you're one location. Yes. in the middle of all of it. Mm-hmm. And the other thing that strikes me is I go back to an interview that I had pretty early on in healthcare rounds. This probably goes back to like 2018 or 2019. Mm-hmm. And I was asking a chief medical officer, we're talking about social determinants. Mm-hmm. So this is pre-COVID, as I said, about 2018, 2019. Mm-hmm. And I was asking about how they track these various issues in the EMR. And mm-hmm. he said, his response to me was, we don't, number one. Mm-hmm. And I don't think he was being, apologetic for his institution, or he was describing it in a way that he felt that he could change things. It was more like, if I can't do something about what I just learned, because doctors like to fix things, right. We're natural fixers. And if I can't do something about it, it wasn't like he was saying, I don't see it, I don't want to know about it. But it was more like they just didn't have the resources to be able to address these issues. And you gave an example of the woman living on the third floor, right? Mm-hmm. Where you were able to have that. So again, I don't know what your secret sauce is, and I'm sure that every day isn't like roses, but it sounds like you're really, I'll go back to what I said a minute ago, a part of the fabric of the community in the area, and that people trust you, and that trust is very, very important to you as well.
Yes, I think I have the benefit that my family has been in social service for over 40 years now. My mother started a homeless agency, outreach homeless agency out of our home in 1984. And so we were one of Chicago's largest homeless outreach. We have a team, I sit on the board still, and that goes out into the community and really engages with the unhoused population. And we talk about, what we can do to help. And so I've been in social service through that vis-a-vis my mother for a number of years. And my entire family, immediate family, is in healthcare or human service. My mother's is still the executive director of that. My older sister is the COO of that organization. My middle sister is the COO of one of the largest FQHCs in Illinois. My daughter is a licensed clinical social worker, so I think I was born, and I may have an advantage over some because I've been able to really look at things on a more grassroots basis and through experience. I've had a lot of personal experiences and interactions, even growing up in my early 20s, being a young single mother on public aid and having to navigate difficult systems and trying to understand how do you get access to the care you need for yourself and for your my daughter at the time. And so I think I'm well bred from every aspect and have a really great understanding of it can't be a one way cookie cutter approach to individuals. Our stories are different, our struggles are different. There is some commonalities that exist, but you really have to provide patient-centered care and individualized care if you want to really make a difference.
It sounds like it's in your DNA, Tesa. I
Yes.
mean, it's like you've been there, and I wonder how. I guess sort of as a last question, I want to get to some lightning round questions, which are always fun, but how you encourage others in the nursing community, in the other allied health professional community, and physicians. Like, how do you encourage them to have the same level of dedication and get into, frankly, I mean, this is service work. So you're not doing, well, I don't want to disparage anybody in Scottsdale here from where I'm from, but you're not doing, let's say convenient procedures. This is very, very serious business. So how do you encourage others to follow your path?
Oh, I think every day it is mentoring moments, letting them know that they are just as important as our patients. The healthcare can count on sometimes we carry on that trauma or we internalize when someone comes in and they may express themselves differently because they're scared or and feeling vulnerable, and we take that on. And it is really to say, listen, we've got to put ourselves in their shoes. Again, we don't understand their stories and their struggles. They're here because they're looking for someone to help them, to support them, to help them navigate a very complicated system. And really finding individuals that are just quite honestly committed to the work. They recognize that, now more than ever in America, it is expensive to be poor. And not everybody has somebody, but when they walk through our doors, we're going to be their somebody. We're going to help them as much as we can, and then we're going to partner with them with some of our other providers to get them any additional, resources or services that they may need when they leave our care. And so, again, fostering that collaboration and that connection is really critical for team members to understand. And then you get to know patients on a different level. You get to know, I have one that comes in and he tells me, every time he's in recovery and as soon as I'm done, I'm going to come. I'm going to apply for that job. And I'm saying, yes, you come see me. I'm a very accessible CEO, very open door. I love to meet and collaborate. I love to learn and from our patients, from our employees. I believe that every great leader is a great listener and learner, student and steward. And so I try to mentor that and mirror, get my team to mirror that throughout the day to day. But it is making them know or letting them know that they are not in the trenches alone. This work can be hard and challenging, but that you have a leadership team and a leader that is there with them all the way.
You're very inspiring, Tesa. I have to say, it's an inspiring story, and yeah, I want to know more. I want to have you come back here and let us know how things are progressing. So, just as a little bit of fun, these are kind of one word or one phrase answers. I've got a few questions, and so just give top of mind, like what comes first to mind. No, nothing tricky here. So first one is one myth about safety net hospitals.
that the care, one word. Oh,
Or word or phrase.
that the care is less than
Less than.
your larger. Mm-hmm.
One metric that you obsess over.
Clean claims.
I love it. I love it. A leadership habit that helps keep you grounded.
Rounding.
And what gives you hope in your community?
Just that one person who comes and says thank you, or the thank you letters when you know that you've made an impact in someone's life. That's what keeps me going. It is, you can't, you won't see tremendous impact at one time, but every day that you know that you've helped somebody is a day well spent.
And then finally, and we could spend an entire hour on this, but this is just top of mind. The death gap that you talked about, mm-hmm. that will close when?
If I have anything to do with it, 5 to 7 years.
5 to 7 years. I love it. Mm-hmm. Again, Tesa, this has been great. And I appreciate your taking the time to talk to us today. And please come back. Let us know how things are going. If you've got any new initiatives, keep me posted. And again, thank you for your time.
Thank you for having me. I look forward to coming back.
Well, that'll do it for another episode of Healthcare Rounds. I'm John Marchica, CEO of Darwin Research Group. If you like what you've heard today, please make sure to forward this on to others. And we'll see you next round.